Hypokalemia. A. Etiology. Profound diuresis without adequate potassium replacement. Potassium excretion parallels the urine output after bypass, which tends to be copious because of hemodulation. The use of potent diuretics may produce a significant diuresis and chaluresis in the early postoperative period. Insulin to treat hyperglycemia, alkalosis, metabolic or respiratory. 4. Significant nasogastric tube drainage. B. Manifestations. The primary concern with hypokalemia in the cardiac patient is the induction of cardiac reentrant arrhythmias due to enhanced cardiac automaticity and delayed ventricular repolarization. Hypokalemia may produce atrial, junctional, or ventricular ectopy, premature atrial contraction, premature ventricular contraction, paroxysmal atrial and junctional tachycardias, AV block, and ventricular tachycardia, also fibrillation. The ECG may demonstrate flattened ST segments, decreased T wave amplitude, and the presence of U waves. Factors that may promote the development of hypokalemic arrhythmias include myocardial ischemia, enhanced sympathetic tone, often from epinephrine or beta-2 agonists, digoxin, and low magnesium levels commonly seen after cardiopulmonary bypass. Hypokalemia can also result in weakness involving the respiratory muscles, the gastrointestinal tract, producing an ileus, or the skeletal muscles. C. Treatment. Treatment is indicated for any potassium level below the normal range. Also, a level lower than 3.0 milliequivalent is usually present before ECG changes become evident. It is essential that renal function and urine output be evaluated before a potassium chloride drip is started, because acute hyperkalemia can develop very rapidly when oliguria or renal dysfunction is present. A slower infusion rate is advisable in this situation, with frequent rechecking of the serum potassium level. In the ICU setting, potassium chloride is administered through a central line at a rate of 10 to 20 milliequivalent hour, mix of 20 milliequivalent 100 milliliter normal saline or 0.45% normal saline. A dextrose carrier should be avoided because it may lower the potassium level by stimulating secretion of insulin. The serum potassium rises approximately 0.1 milliequivalent liter for each 2 milliequivalent of potassium chloride administered. Repeat potassium levels should be guide therapy. When a central line is not present, a concentrated potassium drip cannot be administered peripherally because it scleroses veins. The maximum concentration of potassium chloride that can be administered peripherally is 60 milliequivalent liter. Oral potassium to 10 to 20 milliequivalent tablets up to 3 to 4 times a day will usually suffice for potassium levels of 3-4 milliequivalent level. However, doses of 40-60 milliequivalent 3 to 4 times a day may be necessary to maintain normal potassium levels when the potassium is below 3 milliequivalent liter. Particular attention should be paid to sources of urinary or gastrointestinal loss of potassium that may require more aggressive replacement. This is another section. This is hypocalcemia. Hypocalcemia. Calcium plays a complex role in myocardial energetics and reperfusion damage. Ionized calcium normal 1.1-1.3 millimole liter should be measured because total calcium levels which are affected by protein binding usually decrease during surgery because of hemodulation, hypothermia, shifts in pH, hypomagnesemia, and the use of citrated blood. Hypocalcemia is usually associated with prolongation of the QT interval on the ECG tracing. It reduces cardiac sensitivity to digoxin. B. Treatment. It is common practice to empirically administer a 500 mg bolus of calcium chloride at the termination of bypass to support systemic vascular resistance and possibly increase myocardial contractility. It is also commonly mixed with protamine to offset its vasodilatory effects. It is questionable whether treatment of hypocalcemia identified in the ICU is of any value in improving cardiovascular function. In fact, calcium salts may attenuate the cardiotonic effects of catecholamines such as dobutamine or epinephrine, although they have little effect on the efficiency of milrinone. Nonetheless, if the ionized calcium level is measured and found to be below 1 millimole liter, calcium gluconate 10 milliliter of 10% solution in 50 milliliter dextrose may be given over 10 to 20 minutes, although there is no clear benefit to going so. It may also be given as an infusion of 50 milliliter hour of a 10% solution, placing 100 milliliter in 1 liter of dextrose. Calcium chloride is best avoided for asymptomatic hypocalcemia to minimize any acute hemodynamic effects, but similar dosing is used. Because hypocalcemia can be difficult to correct if the serum magnesium levels is low, an infusion of magnesium sulfate 2 grams 16 milli equivalent of a 10% solution over 10-20 minutes may be given with a subsequent infusion of 1 gram in 100 milliliter of fluid per hour. Calcium chloride 0.51 gram IV may be given in emergency situations to provide temporary circulatory support when a low cardiac output syndrome or profound hypertension develops suddenly. The transient improvement in hemodynamics allows time for analysis of causative factors and the institution of other pharmacologic support. Calcium chloride should not be given routinely during a cardiac arrest. Hypomagnesemia. Magnesium plays a role in energy metabolism and cardiac impulse generation. Low levels have been associated with coronary spasm, low cardiac output syndromes, prolonged ventricular support, a higher incidence of postoperative atrial and ventricular arrhythmias, perioperative infarction, and a higher mortality rate. Magnesium levels, normal 1.5-2 milliequivalent level, are usually not measured during surgery but are reduced in the majority of patients. This is usually the result of hemodulation during cardiopulmonary bypass as well as urinary excretion, but it is also very common in patients undergoing off-pump surgery. Administration of magnesium sulfate 2 gram in 100 milliliter solution to raise the serum level to 2 milliequivalent liter is effective in reducing the incidence of postoperative atrial fibrillation, ventricular arrhythmias after both on-pump and off-pump surgery. Notably, magnesium has been found to inhibit the vasoconstrictive response to epinephrine but not its cardiotonic effects. Administering 1-2 gram of magnesium sulfate at the conclusion of bypass and on the first postoperative morning can be recommended.